Good morning, students. Our today's topic for discussion is relation between the arteries of thyroid gland and nerves of larynx. Before starting anatomical discussion, let us discuss this clinical problem. Four patients were operated for thyroid neoplasms. In the post-operative period, one of them presented with hoarseness of voice. The second patient presented with difficulty in breathing and stridor. The third patient presents with low-pitched voice, and the fourth patient presents with hypocalcemia in the post-operative period. Explain anatomical basis of these complications. To explain these clinical problems, let us first go to the functions of larynx. The functions of the larynx are it acts as an airway, which is the most important function of the larynx. It is also called voice box because it produces sound. It also prevents aspiration of fluids and food during deglutition. These functions are performed by the laryngeal musculature. Airway entry is facilitated by abduction of the vocal cords. In phonation, adductors of vocal cords play an important role. Adductors also prevent aspiration of fluids. Now, what is vocal cord paralysis? It is also known as the recurrent laryngeal nerve paralysis or vocal fold paralysis. It results from injury to one or both recurrent laryngeal nerves, which control all muscles of larynx except cricothyroid. Cricothyroid is tensor of vocal cords. The recurrent laryngeal nerve is important for speaking, breathing, and swallowing. Paralysis of laryngeal nerves and their consequences. Unilateral injury of recurrent laryngeal nerve typically results in hoarseness of voice. Hoarseness is an abnormal voice characterized by coarse and breathy quality of voice. It is caused by reduced mobility of one of the vocal folds. It may also cause minor shortages of breath as well as aspiration problems, especially concerning liquids. A bilateral injury causes the vocal folds to impair the airflow, resulting in breathing problems, stridor and snoring sounds, and past physical exhaustion. This strongly depends on the median or paramedian position of the paralyzed vocal folds. Hoarseness of voice rarely occurs in bilaterally paralyzed vocal folds. Low-pitched voice is caused due to cricothyroid paralysis. Now let us explain all these terms based on the functions of laryngeal muscles. Abduction is movement of vocal cords away from each other. It is brought about by posterior cricoarytenoid. Adduction is approximation of the vocal cords with each other. Cricothyroid is the only tensor of the vocal cords. Tension in the vocal cords is needed for the production of high-pitched sounds. Positions of the vocal cords. Median position is midline position of the vocal cords. Paramedian is when vocal cords are at a distance of 1.5 millimeters from the median plane. Cadaveric position is also called intermediate position, in which vocal folds are at a distance of 3.5 millimeters from the median plane. In partial abduction, vocal folds are at a distance of 7.5 millimeters from the median plane, and in full abduction, vocal folds are at a distance of 9.5 millimeters from the median plane. In this diagram, various positions of the vocal cords have been shown: median, paramedian, cadaveric, partially abducted, and fully abducted positions. Now, what is vocal cord paralysis or paresis? Vocal cord paralysis is defined as total interruption of nerve impulse resulting in no movement of laryngeal muscles. Paresis is defined as partial interruption of nerve impulse resulting in weak or abnormal movements of the vocal cords. A word about Simon's law. Simon's law states that in a progressive lesion of the recurrent laryngeal nerve, the abductors are paralyzed before the adductors. This means that in an incomplete paralysis, the vocal cord will be brought to midline by adductors, but in complete paralysis, it falls away to the paramedian position. After discussing these terms, let us go to our main topic, that is relation of arteries of thyroid with nerves of larynx. As shown in this diagram, thyroid gland is supplied by superior thyroid artery, which is a branch of external carotid artery. This vessel is accompanied by external laryngeal branch of superior laryngeal nerve, which passes over inferior constrictor muscle of the larynx and is accompanied by superior thyroid vessels up to the upper pole of the thyroid gland. Recurrent laryngeal nerve is a branch of vagus On the right side, it hugs around the first part of the subclavian artery, enters trichoesophageal groove, and is accompanied by inferior thyroid artery in trichoesophageal groove. On left side, this nerve is given in relation to the arch of aorta, but again lies in trichoesophageal groove and comes in close relation with inferior thyroid artery. In addition to superior and inferior thyroid arteries, thyroid gland is also supplied by thyroid ima. Ima means unpaired. Another source of the blood supply to the thyroid gland, besides these defined vessels, is small vessels originating from tracheal and esophageal arteries. Thyroid gland is drained by superior, middle, and inferior thyroid veins. Now the question is where to ligate inferior thyroid artery during surgery. Now if we ligate inferior thyroid artery as away as possible from the gland as shown in this diagram, we prevent injury to recurrent laryngeal nerve. At this stage, I would like to ask you a question. Where from the blood supply to parathyroid gland comes? Parathyroids are supplied by terminal branches from inferior thyroid artery. Now, by ligating inferior thyroid artery as away as possible from the thyroid gland, parathyroids lose their blood supply. It is equivalent to parathyroidectomy. The function of parathyroids is to secrete parathormone, which increases serum calcium levels. So by this procedure, there is decrease in serum calcium level leading to hypocalcemia. So in order to preserve the blood supply of parathyroid, inferior thyroid artery should be ligated as close as possible to the thyroid gland. At this stage, we must remember the relations of inferior thyroid artery with the recurrent laryngeal nerve. The commonest presentation is that recurrent laryngeal nerve lies posterior to inferior thyroid artery. The second commonest position is that recurrent laryngeal nerve lies anterior to the inferior thyroid artery, and in some percentage of the cases, recurrent laryngeal nerve lies between the terminal branches of inferior thyroid artery. As shown in this diagram, inferior thyroid artery passes anterior to the recurrent laryngeal nerve in most of the cases. Second commonest position is that inferior thyroid artery passes posterior to the recurrent laryngeal nerve, and in some cases recurrent laryngeal nerve passes between the terminal branches of inferior thyroid artery. Now, what are the consequences if we injure the recurrent laryngeal nerve? Injury to the recurrent laryngeal nerve can be unilateral, which results in ipsilateral paralysis of all intrinsic muscles of the larynx except cricothyroid. You must know that all muscles of the larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Unilateral injury of recurrent laryngeal nerve is usually asymptomatic, or it can present with the hoarseness of the voice. The vocal cords thus assume a median or paramedian position and does not move laterally on the deep inspiration. The affected vocal cords thus assumes a median or paramedian position and does not move laterally on inspiration. The voice in unilateral paralysis gradually improves due to compensation by healthy cords, which crosses midline to meet the paralyzed one. Thus, it may not present with the hoarseness of voice. In bilateral paralysis, both recurrent laryngeal and superior laryngeal nerves on both sides are paralyzed. It is a rare condition. Both cords lie in cadaveric position, leading to total anesthesia of larynx. It is pertinent to mention above the vocal cords, mucosa of the larynx is supplied by the internal laryngeal nerve, and below the vocal cord it is supplied by the inferior laryngeal nerve, which is a branch of recurrent laryngeal nerve. There is gallonous anastomosis over the vocal cords. So vocal cords receive their sensory innervation both from internal laryngeal and inferior laryngeal nerves. So bilateral injury of the recurrent laryngeal nerve leads to aphonia as vocal cords do not meet at all due to paralysis of adductors. It may lead to aspiration due to incompetent glottis and laryngeal anesthesia. Bronchopneumonia is also a complication of bilateral recurrent laryngeal nerve paralysis. Paralysis of superior laryngeal nerve. Paralysis can be unilateral or bilateral. Superior laryngeal nerve gives internal and external branch. Internal laryngeal branch pierces cricothyroid membrane, supplies sensory innervation to mucosa of larynx above the vocal fold. External branch supplies cricothyroid. Cricothyroid muscle tenses vocal cords. Its paralysis leads to wavy or vocal cords and decreased pitch of voice. As shown in this diagram, after paralysis of cricothyroids, vocal cords become wavy or flabby. The sound thus produced by vibration of these flabby cords is a low pitch. So paralysis of the cricothyroid increases the length of the vocal cords. They become wavy. Less tension in the vocal cords. Low pitched sound is produced. To understand the anatomy of note production by the vocal cords, let us go to this simple musical instrument. Presently, the tension in the threads of this musical instrument is high, so the note produced will be of high pitch. Now, if we reduce the tension in the thread, the note produced will be of low pitch. Where to ligate inferior thyroid artery during thyroid surgery? In textbooks of anatomy, you'll find it should be ligated as away as possible from the gland in order to protect recurrent laryngeal nerve. But surgical books mention that it should be ligated as close as possible to the thyroid gland in order to superior blood vessels of parathyroid gland. As shown in this diagram, superior thyroid artery should be ligated as close as possible to the upper pole of the thyroid gland because of the fact superior laryngeal nerve divides into internal and external laryngeal nerves. Internal laryngeal nerve pierces cricothyroid membrane to supply the mucosa of the larynx of a vocal call. External laryngeal branch of superior laryngeal nerve passes over the inferior constrictor muscle of the pharynx. It is accompanied by superior thyroid vessels. Superior thyroid artery acts as a guide and should be ligated or secured as close as possible to the thyroid gland. This prevents injury to external laryngeal branch of superior laryngeal nerve during thyroidectomy. Superior laryngeal branch of external laryngeal nerve supplies cricothyroid muscle, which is tensor of vocal cords. Superior thyroid artery acts as a guide for superior laryngeal branch of external laryngeal nerve, so should be ligated as close as possible to the gland to prevent injury to superior laryngeal branch of external laryngeal nerve. Injury to superior laryngeal branch of external laryngeal nerve, which supplies cricothyroid muscle. In case of injury to nerve supply of the cricothyroid, the glottic chink appears oblique during phonation. The epiglottic fold on the affected side appears shortened and the one on the normal side is lengthened. The cords may appear wavy. The symptoms include frequent throat clearing and difficulty in raising the vocal pitch. I want to summarize my lecture as thyroid gland receives its blood supply from paired superior and inferior thyroid arteries. Superior thyroid artery is intimately related to the external laryngeal branch of superior laryngeal nerve, and inferior thyroid artery is closely related to recurrent laryngeal nerve. Injury to nerves of larynx during ligation of thyroid artery produces symptoms like low-pitched voice in case of superior laryngeal nerve injury and hoarseness and difficulty in breathing or stridor in case of recurrent laryngeal nerve injury. Let us go for a quiz based on this lecture. In order to preserve arterial supply of parathyroid glands, at which site should inferior thyroid artery be ligated? A. As close as possible to the thyroid gland. B. As away as possible from the thyroid gland. C. Near the lower pole of thyroid gland. D. Near the upper pole of thyroid. A is the correct option. As shown in this diagram, inferior thyroid artery should be ligated as close as possible to thyroid in order to preserve blood supply to superior and inferior parathyroids. The muscle of larynx, which is supplied by external laryngeal nerve of superior laryngeal nerve. The muscle of larynx, which is supplied by external laryngeal branch of superior laryngeal nerve, is interarytenoid, oblique arytenoid, cricothyroid, thyroid. The only intrinsic muscle of the larynx, which is supplied by external laryngeal branch of superior laryngeal nerve, is cricothyroid. Which of the following is most important function of larynx? A. Phonation. B. Swallowing. C. Passage of air. Passage of air is most important function of larynx. true statement about gallonous anastomosis is it is an arterial anastomosis. It is anastomosis between terminal branches of internal laryngeal and recurrent laryngeal nerves. It is an end-to-end anastomosis. D. It is end-to-side anastomosis. B is the correct option. Mucosa of the larynx is supplied by branches of internal laryngeal nerve above the vocal cords, and below the vocal cords it is supplied by the branches of recurrent laryngeal nerve. This branch of recurrent laryngeal nerve is called inferior laryngeal nerve. Mucosa or vocal cords is supplied by both branches of internal laryngeal nerve and recurrent laryngeal nerve through gallonous anastomosis as shown in this figure. Thank you for watching this video. Do not forget to like, subscribe and share this video. Thank you.